Everyone, I'm very excited to be here and I'm glad that you've joined us. I'm assuming that everyone here is either thought about egg freezing, interested in learning about egg freezing, or just want to understand a little bit more about female reproduction and what your options are. So I'm just going to get started. The outline of today's talk will be discussing the physiology of female reproductive aging and really why are we even thinking about egg freezing. How do we assess and what is your ovarian reserve and is that important? And then we'll discuss options for fertility preservation, specifically egg freezing and the process of egg freezing. And then any questions that you will have, we'll have the opportunity to answer. So I'm excited for today here. So the first thing that I think is really unfortunate, but also very important to understand is Mother Nature's double standard. And this is the reason why we're here today. It is because men are born with the ability to continuously produce sperm. So they're constantly making sperm. Every day, millions of sperm are being made. Women, females, or those born with ovaries who have eggs, are born with all of their eggs. So we were born with all the eggs we're ever going to have, and we're constantly losing eggs no matter what it is that you're doing in life. So whether you're using birth control, you've been pregnant multiple times, breastfeeding, not using anything and never been pregnant, it really doesn't matter. There's no way to prevent this. We're all constantly losing eggs. So biology is unfair. And we're going to talk about what we can do about it. So reproductive aging, this graph really shows the fact that we're constantly losing eggs. And really importantly, you actually had more eggs when you were a fetus in your mom's uterus than when you were born. So at around 20 weeks gestation, so when you were 20 weeks in utero, at about 6 million eggs. By birth, it's about 1 million. At puberty, that drops down to about 300,000. So at menopause, basically at around 1,000 eggs, and they're not useful eggs, and you don't have periods anymore and not able to reproduce with your own eggs unless you froze eggs in the past. So at the time of birth, a female fetus has already lost 80% of her eggs. So constantly losing eggs. The follicles, which is where eggs mature, go through about an 85-day journey from development, and eventually ovulation occurs. In early follicles, the oocytes are growing these little follicles that become antral follicles, which we can see on ultrasound, and then a dominant follicle is chosen, and that's where ovulation occurs, and then the egg gets released, and from there, a corpus luteum, which supports a potential pregnancy, develops and either continues to be there in pregnancy or goes away, and then a new cycle begins. So one egg is being ovulated a month after menarche, but you're losing hundreds of eggs a month that don't even make it to ovulation. So it's not that you are just losing one egg per ovulatory cycle. Eggs are being lost, whether ovulation is occurring or not, and it's hundreds per month. So we're losing eggs. Not only are we losing eggs in number, but we're also losing eggs in quality. So as we get older, number declines, but also the quality of the eggs, which is actually even more important than the quantity, also declines. How good are the eggs that we have? That factor is declining with age as well. So as we get older, the number of abnormal eggs, the abnormal oocytes, is increasing. And that's due to a number of different reasons. But remember, if you are, let's say, 20 years old, all your eggs are 20 years old. If you're 40 years old, at that point, all your eggs are 40 years old. They've been with you your whole life. The older the egg is, the more likely when you release that egg, when you ovulate that egg or use that egg to try to conceive, it would be more likely to be an abnormal egg because it is sitting in your body for all those years and is able to undergo multiple transformations and become abnormal. And the most likely cause is abnormal spindle apparatus, which is shown in the picture here, where the egg divides the chromosomes, more likely to make an error in that division process where chromosomes aren't divided equally, and then that egg becomes chromosomally abnormal. But it could also be due to mitochondria, telomeres, cohesion, so lots of different factors that could make the egg more likely to be abnormal the older the egg is. So quantity and quality of eggs are declining with age. Because the quality of eggs are declining, it becomes much more challenging to get pregnant. So if we have an abnormal egg that gets released and that egg meets sperm that month, and if it's abnormal, most likely fertilization won't occur. A female gets her period and then you try it next month. So abnormal egg gets released, most likely no pregnancy occurs. Sometimes a pregnancy will occur with an abnormal egg, and if it implants, you get a positive pregnancy test, but often that becomes an abnormal embryo, which then could result in a miscarriage. So as age goes up, abnormal egg quality goes up and risk of miscarriage goes up. And largely that is attributable to abnormal eggs, the quality of those eggs, the chromosomes in the eggs being abnormal. So a higher rate of aneuploidy aneuploidy means abnormal chromosomes. It's a major cause of increase in miscarriage and decrease in live birth rates for women of advanced reproductive age as we get older, which often is defined as 35 or older. Okay. So miscarriage rates, pregnancy gets more difficult, miscarriage rates go up, and the risk of an abnormal, genetically chromosomally abnormal pregnancy goes up, where you could have pregnancy affected by a chromosomal abnormality, such as Down syndrome, which is an extra copy of the 21st chromosome. So those risks go up as we get older. But really, it is much harder to conceive with age. So this graph kind of shows you that with the triangles, and the first graph showing that percent pregnancy rate goes down as women age. So years are on the x-axis and percent pregnancies on the y-axis. And so pregnancy rate goes down and live birth rates also go down. And the contrary, what goes up is miscarriage rate. So as we get older, miscarriage rates, the percent of miscarriage goes up. Infertility also rapidly increases after the age of 35. So infertility is the struggle or inability to conceive after 12 months of trying, if you're under the age of 35, or 6 months of trying to conceive, which is having regular intercourse after the age of 35, or not having sperm or egg, or having an infertility diagnosis that could impact your ability to conceive, such as endometriosis or PCOS. So the risk of infertility goes up as we get older. And again, that's because largely due to the age of the oocytes, the quality of the oocytes, and it becomes just much more difficult to get pregnant as the quality goes down. And you can see that after 35, these percent numbers really do go up, and really very, frankly, difficult to get pregnant after 40. Not impossible, but definitely much more challenging. So while biology is biology, we cannot change the fact that we're born with all the eggs that we're ever going to have. And we cannot change that the quality of our eggs is declining, while being healthy and taking good care of yourself really is the most that you can do. Still, age is the most important factor for quality of eggs. So while that's happening, the average age of childbearing has increased over the past, I have 3 decades, but really since the 1970s, really the age of childbearing is creeping up, and more women are having children after the age of 35. So at least 20% of women wait until age of 35 to have children. And more women are pursuing higher education careers and postponing marriage and postponing having children, whether they are deciding to have children single. And at the same time that this is happening, media is giving women the false sense of security and potentially even unrealistic expectations about the fact that we can achieve pregnancy at an older age. So we're constantly seeing women achieving pregnancies in older age. One, it's still possible, it's just more difficult. And two, we don't really know how do they achieve those pregnancies, especially when we're seeing it in the media. Could it be from eggs that these women have frozen in the past, which is what we're talking about today? Could it even be donor eggs? I'm not sure why I have that was interesting. Anyway, so it is possible that women are seeing these unrealistic expectations. I always use Janet Jackson as an example. She got pregnant when she was 50, really didn't comment about how she got pregnant when she was 50. And it was most likely from either donor egg or frozen eggs that she's used in the past. We have Halle Berry that also is getting pregnant, or whoever the new stars are that are conceiving at an older age, which is contributing to our misunderstanding of biology. So what can we do? Well, we're going to talk about the ability for women to choose if they want to freeze eggs. And to do that, the first thing you need to understand is what is your age and how is it going to impact your ability to conceive? So really having a consultation with a doctor and thinking about your age and what your goals are. How many children do you want? Do you want children? Are you sure? Are you unsure? And really thinking about it thoughtfully about, you know, where do you see yourself in the future? And then assessing your ovarian reserve. And ovarian reserve is really a snapshot as to, you know, how many eggs do you have? Do you have a lot of eggs for your age, an average number of eggs, a below average, a very concerning low number of eggs for your age? And that can maybe help you make some decisions or really give you an understanding of where you lie on this continuum of, you know, the most amount of eggs to really almost no eggs, and understanding your possibilities for future conception. So we evaluate it through two ways: laboratory testing, which is blood work, and the most useful blood test that we get is an AMH, which is anti-Müllerian hormone. We also sometimes get FSH, which is follicle stimulating hormone, along with an estrogen. And we also do laboratory imaging, so a transvaginal ultrasound, which is the picture here showing an ovary with these little black circles, which are follicles, and each follicle has an egg in it. And while you can see that there is, you know, there's a number you can count, this ovary will have thousands of eggs. They're just not formed in follicles yet, but the number of follicles gives the gynecologist or reproductive specialist an idea of what the ovarian reserve is. And the more follicles we see, the higher the ovarian reserve. So AMH is this blood test that I was talking about, and it is important to understand that AMH changes as we get older because it is a representation of the ovarian reserve. And we talked about the ovarian reserve getting lower as we get older. AMH also declines with age. And so when you get an AMH value back, you can't say, is this normal or abnormal, unless you also think about how old you are. And so a laboratory cutoff, it really doesn't exist overall. It's really comparing you to what are the averages and normals for your age group. So you can see here in this chart, the 50th percentile for a 42-year-old is an AMH of 1, which that would only be the 25th percentile for a 32-year-old. So age really matters as to what we're expecting to find on AMH. So ovarian reserve changes through our reproductive lifespan. What does the AMH tell us? So we get AMHs very often. I mean, I think I get AMH on every patient that I see. Gynecologists often get AMHs. AMH, first of all, stands for anti-Müllerian hormone, which is produced by cells that surround the egg. So the more eggs we have, the higher this hormone is. What it does not tell us, and I think this is a really important point, is it is not a fertility test. So when you get an AMH, it is not telling you fertile, yes, check, infertile, no, if it's low. It is not telling us whether you're fertile or not. It is telling us, do you have a lot of eggs for your age? So it is important to understand the utility of the test and what we're getting when we're ordering an AMH. It is a predictor of ovarian response. So if you have a very high AMH, above average AMH, or a good AMH for your age, that means you have a good number of eggs. And that means that if we stimulate your ovaries to try to get a lot of eggs for either an egg retrieval for egg freezing or IVF, let's say, we would get a lot of eggs because your ovarian reserve is high. So your response to the stimulation would be great. If you have a low ovarian reserve, your response would not be as high. You would need more medication and we would get less eggs. So it is a predictor of a response to stimulation. And it is also an idea of, do you have a lot of eggs for your fertility left? And if you have a low AMH at a young age, that likely means you will hit menopause at an earlier age than the average age. The average age is 51. And if you have a low AMH, you have a diminished ovarian reserve, which means that you really should start considering family planning and thinking about how you're going to decide whether you want to freeze eggs or not. And do you want one child? Do you want two children? It really gives you a talking point with your doctor about what you should do for your reproduction. But it does not tell you anything about egg quality. So a low AMH does not equal poor fertility, poor egg quality, cannot conceive. In fact, there are studies that show us that women under 35 that have a low AMH have the same ability to conceive as women under 35 with a high AMH, because the ability to conceive month to month naturally is really based on the quality of your egg. If you're releasing one egg out of a pool of 1,000 eggs or one egg out of a pool of 300,000 eggs, that one egg is the egg that's going to get you pregnant, and the likelihood that that egg is healthy is much more important than if you had more eggs left. Okay, so quality of eggs is much more important, which means that age is the most important predictor of reproductive potential. AMH is telling us years of reproductive potential in the future, and also your ability to respond to stimulation. Again, age, this is just repeating the same slide. Age is the most important factor because it tells us about the quality of eggs. So what are the options for fertility preservation? So if you've gotten, you've thought about it, you've talked to your doctor about your age, you've gotten your ovarian reserve testing, and all for further fertility evaluation, and you're deciding on fertility preservation. Well, there's really two big options. One is egg freezing, and the second one is embryo freezing. And we're really going to concentrate on egg freezing today. The major big difference between egg and embryo freezing is egg freezing means it's your eggs that you are able to do anything with in the future. They belong to you and only you. And embryo freezing obviously involves sperm. And unless you're using donor sperm, if you're using sperm from a partner, then those embryos belong to both of you, and you have to make decisions on what to do with those embryos together. So when we're talking about fertility preservation, especially for people that aren't set on a partner to have children with, egg freezing is the way to go. Embryo freezing is an option for those that are together but want to postpone childbearing until the future. The eggs and or embryos are frozen at the time that they're made or retrieved. And so the eggs are frozen in time. If you're 32, when you have an egg retrieval and freeze those eggs, they're going to be 32-year-old eggs. If you come back when you're 40 and you're having trouble getting pregnant at the age of 40 and want to use those eggs, well, the eggs are going to be 32-year-old eggs. You're going to be 40. The eggs in your body are 40. The eggs you froze are 32. And the quality stays a 32-year-old egg. Okay, so that's really important. And so success rates are based on the age of the woman at the time of egg or embryo freezing, not at the time of when they're utilized. Okay, and they can stay frozen for a long time and be useful to you for your future. So why would someone decide to freeze eggs? The reasons are multiple. Those that are not ready to conceive for various reasons. So you're either single and you're waiting for a partner, and you don't desire to use use donor sperm. You are trying to further your career, training, you're in education, financially not ready, not settled in yet to have a child. Or you have a partner and you just don't want to freeze embryos for religious or other reasons. You want to freeze eggs. There's also freezing eggs prior to treatment that could be toxic to those eggs, like chemotherapy, or prior to gender affirming treatment, such as testosterone. So freezing eggs prior to that might be a good idea as well to talk to your physician. The number of women freezing eggs is consistently increasing. You can see on this graph that COVID in 2020 slowed things down a little bit just because clinics were shut down, but overall the numbers keep on rising, and they are higher for 2023 as well. So utilization of egg freezing is going up. Egg freezing, important facts, does not deplete your egg supply. If you remember, we said that you don't just lose one egg per month when you ovulate, you're losing hundreds of eggs. So when we're freezing 10, 5, 10, 15, 20, 30, 40 eggs, those eggs are lost through attrition anyway. And so when we're freezing them, we're giving them the opportunity to mature in your body, and we're freezing them. You're not depleting your ovarian reserve faster by going through an egg freezing process. So that's important. You're not going to hit menopause earlier because you froze eggs. Another thing that most people don't know is it only takes about 2 weeks to actually go through the egg freezing process, and we'll go through what that entails. So it's not, months and months of treatments and preparation to do an egg freezing cycle. There's the evaluation piece, but the treatment piece really to freeze eggs takes about 2 weeks, and it's overall a very safe process. So a little history. 1986, there was a first birth that occurred from a frozen oocyte. And since then, we've really gotten a lot better at freezing eggs. We've gotten really great at freezing eggs because we changed the technique in which that we use. Previously, it was called slow freezing, and now it's called vitrification, which is really rapid freezing that prevents ice crystal formation. And so it allows us to be really successful when we warm the eggs or thaw the eggs. So the survival rate for those eggs are much higher. In 2012, ASRM, which is the American Society of Reproductive Medicine, lifted the experimental label off of egg freezing. And since then, just the numbers have been going up. I do see women that say that I wish I knew about egg freezing before, and they're in their, early to mid or late 40s, even into their 50s. And really, it hasn't been as mainstream or utilized as it is today. So vitrification is a wonderful process that we're able to successfully freeze eggs. And the success rates of using frozen eggs compared to fresh eggs when we're doing IVF is very similar. So if they survive thaw, the success rate of using frozen versus fresh eggs is very similar. And that's why we're really happy to do this for patients if they're interested. So what does ovarian stimulation kind of encompass? So the first thing, everyone thinks about is all the medications that we use for stimulation. There are multiple different meds that we use. In the beginning, really, the goal of doing an egg freezing cycle is for us to get as many eggs as we can so that you have a higher chance of success of using those eggs in the future. To be able to get more than one egg, so in an ovulatory woman going through a menstrual cycle, the brain sends follicle stimulating hormone to stimulate the ovaries to mature one egg, because most people have a singleton pregnancy at a time. But it would be very inefficient for us to do an egg freezing cycle for a woman with one egg at a time. That definitely would take much longer than 2 weeks. It would be multiple cycles. The chance of a successful pregnancy from one egg isn't very high. Okay, an egg does not equal a baby. That's very important. One egg does not equal a baby. There's a chance that egg can make a baby, but you would want multiple eggs to be frozen to increase the chances for that to occur. So we give you medication to stimulate the ovaries. The medication is follicle stimulating hormone, luteinizing hormone, and these are in injection form. What we're doing is stimulating the ovaries to mature eggs so that we can retrieve them from the body. And the maturation process actually has to occur in the ovaries, not outside in the lab, for us to be able to retrieve them. We also need to give you a medication to prevent you from ovulating. So once your hormones go up and you have lots of follicles growing, lots of eggs maturing, you might release them before we capture them. And so we need to give you a medication to prevent you from ovulating prior to that occurrence, which is a third medication that we give. And then finally, when we've noted that all the follicles that we're going to get are grown to where they're going to be, and this is the most amount of mature eggs that we're going to have, we give you a final injection, which really allows you to have an LH surge, which is kind of what your body does for ovulation, to allow the egg to undergo its final maturation and divide the chromosomes. And that is really important for the egg also to come off the follicle wall for us to be able to retrieve it. And we actually do the egg retrieval right before they're released into the body so that we can collect them. So those are the three medications, the three different types of medications, and they are all pretty much injections. They are subcutaneous injections with a small needle. We teach you how to do it. We have incredible nurses to go through it with you. We have instructional videos, and it is hard in the beginning, but after doing it from a few times, women really get used to it and either are able to do it themselves or enlist their friends or partners to help them do it. The injections are scary for some, but we go through it, and it really is 8 to 12 days of this, and average is 10. So it's a lot shorter than most people think. And really, most patients say that it is a lot less scary than they thought it was, and a lot more manageable than they thought it would be. Some medication side effects, of course, are redness and bruising, discomfort at the site. The goal is to get many follicles, so your ovaries will get larger, much larger. And so there's bloating and cramping from that. There's hormone-related changes to the medications. Some people report mood swings and breast tenderness and fatigue and headaches and nausea. Those are all possibilities. Most of the time, it's bloating and pelvic discomfort from ovarian enlargement, and some other mild symptoms. Overall, patients that go through egg freezing do very, very well. And this is different. Egg freezing is different than going through IVF. And what I mean is emotionally different. The portion of egg freezing, the beginning of when we do egg freezing, is very similar and exactly like the first part of IVF. But with IVF, there's a lot of other challenging aspects because IVF is really geared towards most often patients that cannot conceive. And so doing IVF, it is some of their last resort, and really the putting a lot of hopes and dreams into the process of IVF. When we're doing egg freezing for fertility preservation for the future, it really is empowering women to do this process, and really is a hopeful process. And so there's a lot less of the negative emotional aspects of going through an egg freezing cycle, and a lot of women do very well with it. Like I said, it's essentially the first half of an IVF cycle. And most of the time we start around cycle day 3. Sometimes you need to take some birth control pills in the beginning to line up the cycle, and also to prevent eggs from one follicle becoming too large in the beginning. And the medications are taken for about 8 to 12 days. While you're taking those medications, our ability to understand whether you're responding well depends on what your ovaries are doing. And to be able to do that, we have to monitor you. So the dose that we start with and the medication regimen that we start with really depends on the individual. This is very much individualized medicine. We'll be looking at who you are, your age, your goals, your weight, your height, your ovarian reserve, and coming up with a medication regimen. And then we have to respond to what your body is doing and adjust the dose of medication and the length of the stimulation based on your response. So to be able to do that, we do a lot of ultrasounds and blood work, about 4 to 6 through the 8 to 10 day period, to evaluate your ovarian response and to also know when you're ready for that final injection. And so we're doing blood work and we're looking at the ovaries. You can see the first images of an ovary with a few small follicles, and then you start to have more follicles and larger follicles as the medication continues to stimulate the follicles to grow and the eggs to mature. And the final process, so when we see, okay, this is the most eggs that we're going to get to mature in this cycle, you get the trigger shot, and about 35 hours later, we do the egg retrieval. The egg retrieval is done under anesthesia. So you get IV sedation and you are asleep. You do not feel any of it. While you're asleep, what we do is we use a needle that is guided by a vaginal ultrasound that goes through the vaginal wall, right into the ovaries, into the follicles, and retrieves the eggs into the tubes with follicular fluid. So we can see on ultrasound the follicles collapsing and knowing that we've retrieved all the fluid from the follicles. The embryologist can then see under the microscope how many eggs we have. So they look at the follicular fluid, which comes in tubes from the procedure that we do. The laboratory, the embryologists are looking same time as we're giving them the fluid for eggs and collecting the eggs. And then we know how many eggs we have the day of your procedure. So we'll know the total number of eggs that we were able to retrieve. And then later, the embryologist will be able to tell us how many of those eggs are mature, because not all eggs that we retrieve will be mature. We're collecting as many eggs as possible. Some follicles are going to have immature eggs because they're smaller. So we'll know total mature, and those are the ones that get frozen. And then your period starts in about 2 weeks, sometimes a week. And then you move on. So that day you take the day off because you get IV sedation and anesthesia. The next day, most people feel okay. It depends. Some people take the next day off or work from home or even go to work as long as they're not doing anything strenuous. So overall, it is about 2 weeks of work and a day off for anesthesia for the egg retrieval procedure. The process, once the embryologist gets the eggs, they're able to find the mature eggs, and then we freeze them. And again, it's done through rapid freezing, where the eggs are submerged into solution to prevent crystal formation, and then into liquid nitrogen, where within seconds the eggs are frozen. They're put into basically into straws, stored in liquid nitrogen, and monitored daily. So those eggs are frozen and safe for as long as you need them until you're ready to conceive and use them, or sometimes you don't end up using them. That is the egg retrieval process. There are also, so there's risks to the medications, there's risks to an egg retrieval. The risks to an egg retrieval are not very high. This is a low risk procedure, but with any procedures or surgery, there's a risk of bleeding, infection, and injury to surrounding organs. Those risks are very low, less than 1% of those risks. A big question is, well, how many eggs do I need to freeze for a live birth? And the answer to it, as you might have guessed, is, well, it depends on your age. Again, the older you are, the less likely those eggs are healthy, and the more likely we need more eggs. The probability of having a healthy egg declines as we get older. So to find that good egg, we probably need a larger cohort of eggs the older you are. So you can see here, women under 35 or donors, which are under 35, number of eggs are down here. So they need a lot less eggs to have a higher probability of a live birth, which then goes, down and down and down. 44-year-olds need a lot more eggs to have a higher chance of birth. But it doesn't come close to climbing up to the percentiles that we can get the younger you are. There's also a lovely calculator that was established. We can put in your age, number of eggs retrieved, and we can give you an estimate, a percentage rate chance of a live birth, which I think is very useful. So when we do this, women say, okay, well, I'm very comfortable with that percent chance of a live birth in the future. And some say, well, that's too low, and I want to do another cycle. So there are people that cycle through and do more than one egg retrieval cycle at a time. So that's also a possibility. And for some, the egg retrieval wasn't too bad. And for others, going through the process was either too financially inhibitory, too time consuming, or they didn't like the side effects of the medications, and it was too difficult to go through, and they don't do another egg retrieval. But most people, I haven't really talked to anyone that has said, gosh, I wish I didn't freeze my eggs. Now, what can happen is, and it's very possible, that you freeze eggs and you conceive in the future without a problem, and you actually don't need those eggs. It's also possible that you conceive no problem and then need the eggs for, a second or a third child. So the possibilities are there, and the younger you are when you freeze your eggs, the higher the chance that those will be healthy eggs and more likely to result in a live birth. So ovarian reserve is often age related. However, a significant amount of women that are young can have an accelerated loss of eggs and may have a lower ovarian reserve. So understanding your ovarian reserve when making these decisions is important. And we do that again through AMH, which is a hormone blood test, or an ultrasound. Women are born with a finite number of eggs, and they're constantly being depleted. So quantity and quality of eggs are constantly declining. pregnancy rates decrease and miscarriage rates increase as women age. And this is mostly related to the age of the egg, and that is dependent on the age of the woman. Oocyte cryopreservation, which really is, the medical term for egg freezing, may be a good option for some women who are concerned about their biological clock or their ability to become pregnant in the future, or who are not ready to conceive or know that, they're going through, years of training, and they're not going to have a family for a while, or they're really, they're excited to travel and do other things in life before having children, or they're undergoing cancer therapy or gender affirming therapy, and they need to freeze eggs to be able to have a higher chance of conceiving. So egg freezing is an option for many women. Importantly, and I have to state this, egg freezing is not, and people think it is not an insurance policy. It is an opportunity to increase your chance of having a live birth in the future if you're delaying childbearing. But there's no guarantee that those eggs will result in a live birth. The more eggs we have, the younger you are, the higher the chance. So the younger we are when we do this, the better it is for your outcomes. And that increases your opportunity, but it does not ever reach 100% chance. It can get close if you freeze a lot of eggs, but it's never going to be 100%. So women should still try on their own, and if that doesn't work, then go on to using the eggs that are frozen. I hope that you enjoyed this presentation, you learned something, and if you have questions, which I hope you do, I am here to answer them.